Hello, my name is Amit Pawa, and I'd like to thank Santosh and the rest of the organisers of the Norwich Anaesthesia update meeting for inviting me to talk about fascial plane blocks and why we need them within our toolkit. Now, fascial plane blocks have been an area of regional anaesthesia that have attracted much attention recently, have been responsible for a large number of publications, so it seems like a sensible time to ask whether we actually need these. I do have a few disclosures, none of which will impact on my delivery of this talk, other than to say that I have contributed. I do have a plane, I haven't quite got a plane named after me, but I have contributed to the description of one of the new plane blocks. So that's a small conflict of interest. So in the next 30 minutes, I'm going to cover my opinions. We'll go over some concepts, talk about some evidence, and then we'll talk about how fascial plane blocks may have a role in our armamentarium. Now, this might be a little bit controversial, mainly because fascial plane blocks are a little bit like Marmite. There are some people that think they're brilliant, and there are others that cannot stand them. So this has gone on to lead to some disagreements and some arguments, certainly in the literature. And to deal with that, I'm going to start off by giving you my conclusions first, without very much explanation, and then we'll go on to talk into a little bit more detail about them. So cards on the table first. I'm going to give you 5 truths, each of which have follow-on arguments, which we'll expand on during the rest of this talk. Number 1, fascial plane blocks are a heterogeneous group of techniques. They don't all act on the same part of the body. They're not all necessarily used for the same things, and they all act in different ways. Number 2, fascial plane blocks' mechanism of action is largely unknown, and it may not just be one mechanism of action, there may be many mechanisms of action. Number 3, fascial plane blocks are not always predictable. They don't always act the way we expect them to, or don't always act in the same way. Number 4, they may well have a role in the absence of paravertebrals or epidural or spinal anesthesia, and we'll cover that during the talk of the rest of the lecture. And lastly, fascial plane blocks do increase the delivery of regional anesthesia and have the potential to take regional anesthesia to a group of anaesthetists who wouldn't otherwise perform it. Now, we all know for successful regional anesthesia, it involves putting the right drug in the right place at the right time. And nobody has a contention with that. And for plexus or peripheral regional anesthesia, that's really quite logical. We know we've got to get a needle near to the nerve and inject local anesthetic. But how do we find the nerves? And as over time, this process has changed. We started off with landmark guided blocks, and landmark guided blocks tended to get you close to the nerve on some occasions and maybe sometimes not so much, and it was very much an operator dependent technique. Then we had peripheral nerve stimulator guided blocks, and that allowed us to get pretty close most of the time. And then we had ultrasound guided blocks, and with ultrasound guided blocks we were able to get really close. In fact, some would argue maybe too close. So with fascial plane blocks, what's going on? Where are we putting the local anesthetic and where are we putting the needle? Well, the truth is we don't need to see our target with fascial plane blocks. We put our local anesthetic and distend a fascial plane, hoping to get our targets, and many of the time those target nerves are not actually visible. But some people would say that this is a little bit like using a sledgehammer to crack a nut, and maybe we've gone too far, literally and metaphorically speaking, so maybe we've gone too far away from the targets to achieve this. And as a result, some papers have been written talking about being really close to the nerve versus interfascial plane sniper rifle versus a shotgun. That was one paper, and there's another couple of papers here questioning the value or the utility of these techniques. And wherever you see these QR codes, if you take a screenshot or if you hold your camera up to the screen, you'll be taken to the links of these papers. So I just want to get back to focus. There are a large number of innovators. These are the people responsible for coming up with these techniques, for researching them, finding indications. And between this group of advanced regional anesthesia practitioners, we've come up with a whole host of blocks. And this is a small example. Now, some of these acronyms will make sense to you. You'll know what they're about. And some of them you'll think, oh my goodness, what does that mean? What's it all about? There's a whole host of techniques there. I don't know about you, but when I look at that, I think this is a big heterogeneous group. And actually, it looks a little bit like this. That's what I'm thinking. The issue is we've got too many blocks and the nomenclature is inconsistent. But watch this space, because actually there's a big piece of work being done at regional anaesthesia and pain medicine, and hopefully this will be resolved soon. The bulk of my talk will be based upon 3 references, one that I've been involved with at the top, and 2 very recent papers that have come out challenging us and getting us to think about the way that these blocks may work, and asking some questions that I think are worthwhile asking. So now let's focus on the science. I will start off by talking about the anatomy of the fascia. So what is fascia? It's a soft, collagen-containing, loose and dense fibrous connective tissue that permeates throughout the whole body. There are different types of fascias. You've got superficial fascia, you've got a deep fascia, which is multi-layer, and the muscle and muscle-related fascia. A deep fascia is the target for fascial plane blocks. There are multiple layers and extend throughout the whole body, and they form sheaths around nerves, vessels, and organs. The deep fascia is our target. There are a couple of subtypes of deep fascia. We'll start off with the epimysial, which is thin. It's specific to one muscle and is adherent to that muscle. Example would be when you're doing blocks in the pecs area, the tap blocks of serratus. And then there's an aponeurotic subtype of deep fascia, which is thick. It may cover or envelope several muscles and is easily separated from them. And good examples are the rectus sheath or adductor canal. So if we look at that paper by Nick Black, we'll see some nice examples there. So under the epimysial, you can see that fascia, that thin fascia, is tightly adherent to the muscle. And on the right-hand side, you've got the fascia lata here, and you can see how that's a thick sheet, which is easily separated from the muscle. The other concept I want to talk about, or 2 more concepts, the first of the 2 is the lines of fusion. Now, these are distinct fusion points within fascia. Perfect example here would be if you look at the rectus abdominis muscle. In the midline, you've got the linea alba, and then the lateral aspects of the muscle, you've got the linea semilunaris. So these are distinct fusion points, and they create a compartment. So actually, they limit the spread, and for a rectus sheath block, that's a good thing because it keeps the local anaesthetic close to the nerves. But actually, if you were relying on spread within the fascia or outside the fascia, a line of fusion might be a bad thing. That brings us on to pathological lines of fusion. So if you've had surgery before, perfect example would be someone who's had abdominal surgery. When you're performing a tap block, maybe the local anaesthetic wouldn't flow nicely, or breast surgery and you do a PEX block. These pathological lines of fusion may alter the way that local anaesthetic spreads. The converse of that is fascial interconnectivity. These are connections between fascia, and many planes are continuous and they communicate without clear boundaries to them. This may help us to understand the mechanism of action of these techniques. An example here is a thoracolumbar fascia, which is continuous with the endothoracic fascia within the thorax and the gluteal fascia in the lower limb. Now, not all fascias are the same. And as we've said, they may differ by a number of ways, but they may differ by a number of layers. They may differ by function and mobility. And some fascias may be more mobile and may glide on each other, and that may help spread local anaesthetic. But also they may have different surrounding structures, the lungs, the liver, the spleen, and the presence of these structures and positive pressure ventilation or spontaneous ventilation may all influence the way that fascial plane blocks work. So how do they work? Do we have any idea? So local anaesthetic may act on nerves within the injected plane, and that seems relatively straightforward and easy to understand. So if you're doing tap block, you know there are going to be nerves T12 and L1 that lie within that plane. So it makes sense that they would act in that plane. They may also act in nerves in planes adjacent to where you're injecting. And thirdly, they may act in nerves in distant planes, and the way they might get there is by systemic absorption. So what nerves might the local anaesthetic act on? So it could act on cutaneous nerves, and actually that's relatively non-contentious. You do a PEX or a serratus block, you know that you're aiming to get the lateral cutaneous branches of the intercostal nerves. That's straightforward. What about non-cutaneous nerves? So if you think about muscles, ligaments, joint capsules, and bone, they've got silent nociceptors there. And in health, they don't do anything, they don't trigger. But if you get inflammation or injury, these nerves get upregulated, and they may well be responsible for nociception, and therefore local anaesthetic might act on those nerves. There are also nerves that lie within the fascia. These are non-cutaneous nerves, and the fascia itself may be a trigger or a cause of pain. So if you inject local anaesthetic directly to the fascia, it seems to make sense that they may numb those nerves. There are also motor nerves. Now, for the PEX block caused quite some confusion at the beginning because the primary target of the PEX block in the first injection is the medial and lateral pectoral nerves. Now, these are motor nerves, But even motor nerves carry some sensory and nociceptive fibers. And actually, the effect of blocking a nerve and relieving muscle spasm actually may contribute to analgesia as well. So if you were to inject local anesthetic within the injected plane to get a nerve, you can see a needle coming in here. Local anesthetic distends the plane and you cover the nerve. This is using hydraulic pressure of the injectate to cause hydrodissection, and via transmission belts or decompression planes, the local anesthetic reaches the nerve. So the rectus sheath block is a good example, as is the TAP or the PEX block. What about injecting local anesthetic to get nerves in adjacent planes? So over here, you inject local anesthetic, and by bulk flow, local anesthetic moves from one plane to another. Okay, that's relatively straightforward. The other way it might get to adjacent planes is via diffusion down a concentration gradient. And one example here, you can see a schematic of the erector spinae plane block, and how local anesthetic diffuses down the concentration gradient, crosses the superior costotransverse ligament and affects the target nerves. But also, local anesthetic may diffuse to those silent nociceptors. So over here, I've given two nociceptors around the patella of a knee. You can see how local anesthetic from muscles around the knee may drift down to affect those nerves. Now, clearly, when local anesthetic gets to those nerves via that process of diffusion, the mass of drug that's there is going to be much less than the mass of drug injected, and that may well have an implication. And lastly, we talked about the fact that local anesthetic may act at nerves at distant sites via systemic absorption. Here you can envisage local anesthetic molecules going into the circulation and going to some remote site. I also want to talk about this, or focus on this concept of getting there by the back door, or the by proxy. And we coined this term when we were talking about the erector spinae plane block. So if you have a look at how the erector spinae plane block might work, the first part makes sense. You can get the dorsal ramus here by injecting in close proximity to it. You can then may get local anesthetic diffusing towards the ventral ramus and the sympathetics, giving you a paravertebral by proxy. But it may also diffuse and spread in a transmission belt to get the laterocutaneous branch. It may act as a serratus plane by proxy. So lots of potential ways that these techniques might work. The other thing that's worthwhile stressing are the biomechanical properties of fascia. Fascia is dynamic. So you may have a pumping mechanism due to muscle tendon insertions. There may even be contractile elements within the fascia, and these may explain why you get a variable or extensive dermatomal spread just from a localized injection. But we don't know the impact of depth of anesthesia or muscle relaxation and how that will have an effect on the spread of local anesthetic within fascias. So this is a study now trying to look and see whether it made a difference. So it took one volunteer and they performed a suprainguinal fascia iliaca block. On one side, they did nothing. And on the other side, they did passive movement of the muscle to mimic what might happen within a hip replacement. And lo and behold, by passively moving the limb, it altered the spread and the distribution of local anesthetic. So there's a proof of concept that that process may have an impact. Now, there may be local fascial innervation. So we know, as I said already, that nerve elements lie within the fascia, and these may be responsible for nociception. So if you have joint pain, you have associated muscle pain, the fascia associated with that muscle may have active nociceptors in there. And if you numb those nociceptors, that may contribute to analgesia. So these may well influence the way that local anesthetic works. Now, do we have any evidence that injecting in one plane allows local anesthetic to spread somewhere else? And the answer is yes. So going back to the initial studies on the TAP block, here you can see an ultrasound-guided TAP block spreads all the way up to the paravertebral space. They've shown it. Another example here would be a PEX block. You inject in the PEX plane and you cover the intercostal nerves, the medial brachiocutaneous and the laterocutaneous branches. So again, proof of concept. Transmuscular quadratus lumborum block. This is again a very controversial block. You're doing this block low down just above the hip, and you actually get local anesthetic, or certainly in this case, dye in a cadaver, spreading right the way up to the paravertebral space and staining the sympathetic trunk as well, without staining the lumbar plexus. And now the erector spinae plane block is a block that has caused a massive explosion in publications. The initial description showed very clearly that the dye in cadavers spreads up and down and within the paravertebral space. Lots of other people have tried to repeat these studies, and this is another study comparing the erector spinae plane block with the retrolaminar block. Now, although they showed local anesthetic going into the paravertebral space, they thought the amount of dye, or rather dye going in there, was too small to allow for upward or downward flow. Another study here looking at cadavers in ESP, and they only showed local anaesthetic spreading to the dorsal rami. Again, here you can see the ventral rami have been completely unstained. So if we were to summarize the ESP studies, what do we say? Well, certainly there is local anaesthetic that's been shown in cadavers to go to the paravertebral space. Possibly and more reliably get the ventral ramus, but in all of those studies, nearly all of those studies, local anaesthetic stained the dorsal ramus. And this is a link to a paper by Kijin and Karim El-Bogdadli looking at mechanism of action as a fascial plane block. So I would definitely recommend you look at that. So what can we say so far? What we can say is that there is limited evidence of by proxy spread, certainly with the ESP block, and variation exists a lot in cadaver studies. And we know that actually cadaver studies may not mimic real life for a whole host of reasons: ventilation, the way that the cadavers may be fixed or not, the presence of pulsatile flow. There's a whole reason. So cadaver studies can give us only so much information, but there's certainly evidence that you can get spread. So what about controversies with fascial plane block? Well, there are lots, because fascial plane blocks can be unpredictable with inconsistent effect, efficacy, evidence. Actually, it's very rare to get dense neural blockade. So local anaesthetic spread can be affected by the thickness of the fascia. Thick fascia is easy to identify in ultrasound, but would limit diffusion. And as we said before, contain local anaesthetic, like in the rectus sheath block, it keeps it localized and spreads limited. With thin fascia, it may be harder to identify the sonographic landmarks of that. But actually, if it's a thin fascia, it may allow diffusion of local anaesthetic much better, so local anaesthetic spills out of the area. So what would the ideal block be? Here is a lovely rectus sheath block. You can see the muscle peeling back off the posterior rectus sheath. That's really lovely. And you can imagine the local anaesthetic will be contained by those lines of fusion. So that's a nice block there with thick fascia, the aponeurotic fascia. What about blocks that are looking in the region of the epimysial fascia? And here are some example of PEX blocks, PEC1 and PEC2 blocks. If you look at the spread of local anaesthetic, even though things are opening out, are you in the right plane? Are you not in the right plane? Have you injected in the muscle? Is that local anaesthetic opening the muscle plane? It's less easy to see. So we don't know whether that sort of spread is good enough. Now, we know now from a paper very recently that even when you get local anaesthetic with the correct plane, local anaesthetic does not stay there. So they performed a tap block study, and when they looked in detail, they noticed that injecting spread into the internal oblique and into the transverse abdominis muscles via the perimysium. So actually, we know that just because you inject in those spaces doesn't mean the local anaesthetic stays where you want it to. So what receptors lie within the fascia? We've got somatic nerves, so sensory and motor nerves, and for example, the lateral cutaneous nerves, and that makes sense, or the lateral pectoral nerves. But they have a variable path within the fascia. We've got sympathetic nerves and nerves within the fascia. Now, if local anaesthetic was to act on sympathetic nerves and nerves within the fascia, so in the fasciatome, that might explain why you're able to get a successful block without any cutaneous loss of sensation. And this is one of the problems with fascial plane blocks. And maybe actually the reason you've got a successful block without cutaneous manifestation is it's not acting on those nerves. So if you don't get a dermatomal loss of sensation, does that mean you've got a failed block? And the reason I'd say no. And the reason for that is you get analgesia and opioid reduction even when you check the skin afterwards and they haven't got a loss of sensation. It may be due to getting a differential block. It may be that you're numbing C fibers preferentially to A delta fibers, and A delta fibers obviously give you pinprick sensation. So it may be that you don't lose the A delta fiber innervation, but you do preferentially block C fibers. So does it really matter if the patient's better afterwards? Does it matter if you can't demonstrate a cutaneous loss of sensation? Some people would argue what's more important is to look at patient-reported outcome measures and define the minimum clinically important difference when you're looking at scores such as the quality of recovery scores. So what is clinically meaningful to a patient, and what do you need to do to get them feeling better? The other thing to talk about is that anatomical cutaneous innervation is complex. It's not quite as straightforward as in the textbooks. So there are many structures where actually you're doing a block on one side, but there may be contralateral innervation or overlapping innervation across the midline. And between individuals, the way that this process happens obviously varies significantly. There's also variability in pharmacokinetics and the amount of local anesthetic that actually gets to the target where you want it to act. Um, and also, we all like to think we're putting local anesthetic in the correct place, but it's possible that we're actually not finding the correct target. And as a result of that, you get a variable spread. And we also, as mentioned before, there are non-cutaneous contributions to nociception. So we know that cutaneous manifestations of a block is not necessarily relevant for a successful block, and there are many reasons why that might be the case. So how might we improve efficacy? Well, we could simply take local anesthetic and deposit it closer to the target. So rather than doing a lateral tap block where we're further away, do a rectus sheath block closer to the midline. Instead of hedging all of our bets on, or instead of putting all of our money on one horse and injecting local anesthetic at one space, maybe we should consider fractionating our dose of local anesthetic at more than one site to give a better chance of spread and give more chance of getting an effective block. If we're talking about diffusion, maybe we need to deposit a larger concentration of local anesthetic so there's a greater mass of drug available to act. Of course, when we're doing that, we need to be aware and make sure we stay within toxic limits because of local anesthetic systemic toxicity. And maybe we should be using epinephrine as a rule to minimize the systemic absorption. The other thing we might be able to consider doing is using catheters. And if you're going to use a catheter, because of the way we've talked about blocks working, intermittent boluses to distend the plane and increase spread may be beneficial. So what about clinical studies? What does the evidence say about these fascial plane blocks? I've picked this one because it's literally hot off the press. It's a recent study. This was a systematic review and network meta-analysis. They showed that tap blocks and quadratus lumborum blocks were better than control in cesarean section. But actually, when you added intrathecal morphine, that benefit was lost. Another paper here, again, looking at quadratus lumborum blocks, and also looked at cesarean section, but what it additionally added was that in abdominal wall and hip surgery, quadratus lumborum blocks were better than placebo, so there's a role, there's an indication for them. But when you compared them with active comparators, the benefit was less exaggerated. There's been a whole host of studies looking at the rectus spinae plane block, lots of case studies, and we're starting to get some systematic reviews now. But what do they say? They say that these techniques reduce pain scores and they reduce opioid requirements, but generally speaking, when compared to a control or compared to systemic analgesia, now more and more comparative studies of these active comparators are coming out now, so watch this space. What about meta-analysis? And there's a whole host of meta-analysis of PEX blocks, and there's more that have come out since here. And what do they say? They say that PEX blocks reduce pain scores, they reduce opioid requirements, and they may even be as effective as thoracic paravertebral block. So again, another hot off the press is only released on Monday, the 11th of January 2021. In this paper, we summarize all of the ultrasound-guided fascial plane blocks and talk about the evidence. But the main headlines are there are some chest wall blocks, such as PEX, serratus, and ESP, that have a significant benefit in breast and thoracic surgery, and in many cases similar to thoracic paravertebral block. And their role in trauma and cardiac surgery is developing and holds great potential. So please check out that article. So where may fascial plane blocks have a role? So certainly, if there's no spinal, epidural, or paravertebral block, that's where fascial plane blocks may have a role. And that may be because of coagulation concerns, because of sepsis, so you don't want to put an epidural catheter in, or in certain surgical specialties, such as cardiac surgery or transplant surgery, where you wouldn't normally put a regional anesthetic technique. They may have a role where you want to avoid the side effects of the more central neuraxial blocks, such as hypertension, and actually that's where fascial plane blocks may have a role. We may need to use them if the primary technique we performed hasn't worked, so we may need them as a rescue technique. It may be that actually we can't perform an epidural or paravertebral, and that may be because if you remove the coagulation issues, maybe the patient's unable to move onto their side or prone or sitting up in order to site a block. Or it may be, this is something that's becoming more relevant nowadays because we don't have enough skilled practitioners to perform them. Certainly, if you think about the number of thoracic epidurals that most centres provide now, there's certainly less than I think we used to in the past for a whole host of reasons. I've heard recently that some people are unable to send patients with thoracic epidurals to a standard ward because they don't have the nursing staff available to do it. So certainly if you can't site an epidural, a spinal, or a paravertebral block, they may be a role for fascial plane blocks. And certainly what it does is it gives us options. So let's have an example here. If you couldn't cite a paravertebral block, say for rib fractures or for breast surgery, you do a PEX block, serratus plane block, an ESP, or a midpoint between the transversus process and the pleura, an MTP block. If you couldn't cite an epidural for rib fractures or for abdominal surgery, you could do a rectus sheath block, a TAP block, maybe a quadratus lumborum block, a serratus plane, an ESP if it's for the chest. So there are a whole host of potential ways that we can use these techniques, and certainly fascial plane blocks give us options. They also increase access to regional anaesthesia. Much of ultrasound guided regional anaesthesia is daunting to the uninitiated. We're not all experts. The whole concept of fascial plane blocks is simple. We've got superficial planes such as rectus sheath, the PEX, and the TAP block. And a lot of them share a similar technique in terms of splitting a plane of local anaesthetic. And once you've got your eye in, you can try to replicate that. And the idea, we should focus on some plan A blocks or some starter beginner blocks and work from there. What do I mean when I talk about plan A blocks? Well, there's a publication in Anaesthesia in 2020, which regional anaesthesia have taken to endorse, and we've endorsed 7 core plan A blocks. If you look, 2 of those are fascial plane blocks, the chest wall, erector spinae plane block, and the erector sheath for abdominal midline. It's also important to think about skill progression. So if we really think honestly, there are very many people that would be too scared or don't have the skill or not confident to perform a paravertebral block. But many of them would actually be able to start off by doing an ESP block because it's simple. It's the type of block that many people can do because it's simple, it's superficial, the risks are low. You may not get as good an effect as a paravertebral block, but it's a starting point. So you start off by doing an erector spinae plane block. Once you get the skill and the confidence to do an erector spinae plane block, you advance your needle a little bit further and go midway between the transverse process and the pleura and do an MTP block. Because you're getting a bit closer to the target of the paravertebral space, that may well give you a bit more bang for your buck. You may get a more dense block. And then once you've got the confidence taking your needle there, you can take that final step and put your needle within the paravertebral space and perform a paravertebral block. So you can use fascial plane blocks as part of skill progression to learn a technique. So what are the takeaway points? So we're coming to the end now. So the conclusions, as I stated at the beginning, fascial plane blocks are heterogeneous. They have an unknown mechanism of action with unpredictable efficacy, but they may well have a role where there's no epidural or paravertebral block, and also they help us to increase the delivery of regional anaesthesia by those who don't necessarily have a large skill base, but we can start with simple techniques that may give patients some benefits. Why do we need fascial plane blocks in our toolkit or in our armamentarium? Well, regional anaesthesia is an important part of multimodal analgesia, and it's important that we should give patients the best possible medicine that we can. So regional anaesthesia is a core part of that. We do need to increase the delivery of regional anaesthesia so that more patients benefit. We can minimize the use of opiates, enhance recovery, and fascial plane blocks have a role there. Some fascial plane blocks are simple to teach and to perform, and it's important that we increase the workforce's ability to deliver these techniques. And we also need alternatives when we can't perform our classic blocks or when they fail.